Hi, I'm Sherilyn Smith, a pediatric infectious disease doctor at the University of Washington, and in this video you will learn about the potentially life-threatening illnesses meningitis and encephalitis. We will be focusing on the clinical presentation of these illnesses because rapid recognition and treatment of the illness may allow you to save someone's life in the future. Here are the learning objectives: to compare and contrast meningitis and encephalitis, and to outline a diagnostic approach to the patient with meningitis. First, I'd like to define some of the terms I'm going to be using. The different layers of the meninges that cover the brain are called the dura, the arachnoid, and the pia mater. As you can see in this cartoon, normally they are very thin membranes that cover the brain. Cerebral spinal fluid, or CSF, is in the subarachnoid space, which surrounds the brain. This fluid serves to cushion the brain, provides nutrients and chemicals from the blood, and removes waste from the brain parenchyma. Meningitis is inflammation of the meninges. You can see here in the photo of a patient who died from meningitis due to strep pneumoniae that when there is inflammation of the meninges, they become thickened and no longer translucent. Patients who have meningitis will have fever, headache, and stiff neck or nuchal rigidity. Encephalitis is defined as inflammation of the brain tissue, as shown in the cartoon. The image in this slide is from an MRI of the brain of a patient who has encephalitis due to herpes simplex virus. You can see that there is increased signal intensity, or white color, where the arrow is, indicating inflammation. Patients who have encephalitis have fever, change in mental status, and sometimes seizures or focal neurologic symptoms because there's inflammation of the brain tissue. Meningoencephalitis is inflammation of both the meninges and the brain parenchyma and is used to describe patients who have clinical features of both encephalitis and meningitis. It is not surprising that patients could have both processes given the close proximity of the brain tissue and the meninges. These patients have fever, headache, change in their mental status, and possibly seizures or focal neurologic symptoms like weakness. Myelitis is inflammation of the spinal cord. Patients with myelitis can have localized neurologic dysfunction depending on where the inflammation is. Certain infections can cause transverse myelitis, which involves both sides of the spinal cord at a specific level and interrupts the communication between the peripheral and central nervous system. The arrow in this image shows localized inflammation of the spinal cord, which is typical of transverse myelitis. Putting it all together, you can see that patients will likely present with a combination of symptoms and physical exam findings. The specific symptoms and signs can help you localize where the infection is anatomically, and it may help you decide which organisms are more likely to cause infection. And I think of four main ways that patients develop meningitis or encephalitis. The first way is through direct inoculation of organisms into the brain tissue or CSF. We see this most often after head trauma, and the infections are mostly due to bacteria. Another way that meningitis occurs is when an organism is present in the blood causing systemic or whole body infection. The organism can cross the barrier that exists between the blood and the brain tissue through a variety of methods, and we're going to talk about this in the next couple of slides. Sometimes organisms, particularly viruses, directly infect nerve tissue and spread to the brain. And finally, infections in the sinuses around the eyes can spread to the brain directly due to the close anatomic proximity of these structures to the brain. This cartoon illustrates how some organisms can cause meningitis or encephalitis by crossing the blood-brain barrier. Bacteria are in the bloodstream and bind to the endothelial cells via cellular cytoskeletal rearrangements. They are then endocytosed and killed by intracellular mechanisms. However, as part of the immune response, cytokines are released, which results in changes in the tight junctions between the endothelial cells, and leukocytes can migrate into the CNS via chemotactic gradients. So the bacteria can actually take advantage of this change in the tight junctions and pass into the CSF, or they may hook a ride on some of the leukocytes that are coming in to the CSF from the blood. The bottom part of the cartoon helps you visualize how infection of the meninges happens with bacteria moving from inside the blood vessels through the blood-brain barrier and then into the CSF and the meninges. So how do you recognize someone who has meningitis? I already mentioned clues from the history, primarily fever and neurologic symptoms. But when you do the physical exam on a patient with meningitis, there's some specific signs that you're looking for. First, you will see if there is inflammation of the meninges. This is done by stretching the meninges during the physical exam maneuvers as shown in the cartoons. You can see that when you have the patient on their back and they extend their knee, they will have pain in their back. In addition, if you have the patient on their back and you flex their neck, they will involuntarily move their knees due to the pain. These are the Koenig's and Brudzinski signs, and they were first described with advanced TB meningitis. In addition to evidence of meningitis, you will look for specific neurologic defects like weakness and determine how alert and oriented the patient is. Finally, you will do a complete and careful physical exam to find other clues to the etiology of the infection. You may see a rash like this one in the picture called petechiae, which you can see with Neisseria meningitidis infection. Since you may not know exactly what is causing the patient's symptoms when they come in with fever and neurologic symptoms, the initial evaluation is the same for all types of meningitis and encephalitis. The gold standard evaluation is direct sampling of the CSF by doing a lumbar puncture. A needle is inserted in between the vertebra into the lumbar cistern and the subarachnoid space where the CSF is. The standard evaluation we do is determining the opening pressure to find out if the infection is causing increased intracranial pressure, which can damage brain tissue. Bacterial cultures and gram stains to modify therapy quickly. The combination of glucose and protein, which will change with inflammation and can give clues to the diagnosis early on. And always save an extra tube of CSF for more studies. Sometimes, if there's a concern about increased intracranial pressure from the physical exam or the history, we'll obtain a CT scan of the head to make sure we don't accidentally cause a complication related to the lumbar puncture. This table outlines some of the results of the tests we order when we do a lumbar puncture. Keep in mind that specific organisms that cause meningitis or encephalitis can cause slightly different results. It is critical that you recognize bacterial meningitis because it is a medical emergency, and this is outlined on the first line of this table. The combination of lab values that points to bacterial meningitis is a low glucose, high protein, elevated white blood cell count, primarily neutrophils, and a gram stain that shows bacteria. Ultimately, the cultures will grow bacteria, proving that the patient has bacterial meningitis. So why do we see these changes in the CSF? The glucose is low because the bacteria consume glucose and because less glucose is transported into the CSF. The protein is elevated because of increased bacterial replication, bacterial death, recruitment of white blood cells, and increased levels of immunoglobulins and other proteins as a part of the immune response. Normally, white blood cells, immunoglobulins, and complement are sparse or absent from the CSF. This situation allows the bacteria initially to multiply without causing inflammation. Later, bacteria release endotoxins, teichoic acid, and other substances that trigger an inflammatory response. There is an influx of neutrophils and elaboration of additional inflammatory mediators like TNF, which are important parts of the immune system that can control bacterial infection. You can see here that with encephalitis, the glucose and protein are normal. The white blood cell count is elevated, but not to the same degree as seen with bacterial meningitis. The types of white blood cells are lymphocytes, which makes sense because viruses are some of the most common causes of encephalitis, and lymphocytes are critical for control of this type of infection. In summary, meningitis is a potentially life-threatening illness that requires rapid recognition. Your initial clues to this diagnosis are fever and neurologic symptoms. Doing a lumbar puncture is the diagnostic test of choice, and interpretation of the initial CSF results can guide your management.